Okay, now we'd like to move on to the second case. This is about a 68-year-old Caucasian man diagnosed with stage 1 multiple myeloma. And at the time of diagnosis, genetic testing showed a translocation 414 in 50% of the plasma cells by FISH. He was started on treatment with lenalidomide, bortezomib, dexamethasone, or RVD, and then got an autologous transplant. And at day 100, he has an unconfirmed complete remission with RVD and transplant. So we want to discuss the role of maintenance for these patients who are after transplant. And I think one of the most important manuscripts and presentations that we've had about this was a meta-analysis that was first presented at ASCO in 2016 and most recently published in JCO in 2017, looking at lenalidomide maintenance after autologous transplant in newly diagnosed multiple myeloma. Now, this meta-analysis combined 3 different clinical trials and looked at len maintenance versus placebo or observation. So the 3 trials included were the CALGB 100-104. This trial was the American trial that was sort of the partner study to the IFM 2005-02. And in this study, patients underwent transplant and eventually were randomized to lenalidomide versus placebo. In the Jemima RV myeloma transplant trial, the patients actually were randomized to tandem transplant versus not, with the second randomization of maintenance versus not. And the purpose of this meta-analysis was really to combine all the data, because although the American trial had shown some increase in overall survival, it wasn't clear that the other 2 trials also did that. And so we really wanted to understand what was the contribution of lenalidomide maintenance in these patients. So these trials looked at 1,208 patients, which is a really sizable number, looking at len maintenance versus placebo or observation. And here you can see that the PFS was very impressive in the len group, 52.8 months versus 23.5 months in the observation or placebo group. And in addition, the median overall survival at the time of analysis was not reached versus 86 months, which was very significant as well. In addition, the PFS2, so their next PFS after having salvage treatment, was also noted at 73.3 months versus 56.7 months. At this time, the hazard ratio was also at 0.72, showing favorably for the len maintenance group. So just looking at the curve, you can see the blue being the len maintenance versus the gold not being len maintenance. You can see that there's a nice separation between the curves. Looking at the subgroup analysis in the forest plot, you can see that most of the groups benefited from lenalidomide maintenance, although there is some question of whether the higher stage patients benefited, which may be related to the number of patients included in this group. When we look at the len maintenance versus placebo or observation based on previous therapy, you can see that in almost every group of therapies in panel C there was a benefit derived from len maintenance versus not. And if you look at the 3 separate trials, again, the CALGB had the most data for overall survival. Still, if you combine all the data but then look individually, you can see it trended in each study towards having benefit from lenalidomide maintenance therapy. I think this meta-analysis, I really applaud the investigators for doing this because we really needed more solid data. We thought that len was better. We knew progression-free survival had been proven in these studies, but really showing your patients a long-term overall survival outcome is important. And actually, when they presented the data, they showed that there was an actual increase of about 2.5 years for the patients who got len maintenance versus not. And this is something we are able to look at in our practices because we want to justify to the patients why they should be on further therapy or why we think it may be better in certain cases. Now, secondary primary malignancies are a concern, and this has definitely been shown to be increased in the lenalidomide maintenance groups. And you can see here that even before progressive disease, the len patients tend to have a higher secondary primary malignancies, both hematologic and solid tumor. Although theoretically, the risk of PD was actually higher than the risk of SPM in both groups. And for that reason, we tend to think that the risk of getting len maintenance is outweighed by the benefit. And I do present these numbers because there's a relative risk that's increased, which is the sort of multiplying risk, but the absolute risk increase should also be discussed with the patients because it's not as much as the known risk of progressive disease.